Good afternoon, everybody. I think we'll kick off. So first of all, to say I'm actually a late replacement for Salim Shuba. So if you're expecting Salim Shuba to wow and entertain you, I'm afraid you're going to be sadly disappointed because it's just me, the research officer. What I thought I would do is just walk you through some of the basic concepts of major incident, partly because I think it's something that people are sometimes a little bit confused about what we do and what we don't do. So Ollie's recording this. If you have any questions as we go through it, then please, you can use the hand up facility. Sometimes I miss the hand up facility, so probably the easier thing, if you have a microphone, because I don't think Neil has, but if you have a microphone, then just unmute yourself and ask the question if you have anything. But like I said, I am the late replacement for Salim Shuba, so I do apologise if this isn't what you're expecting. So I'm going to talk about major incident, and because I'm on the Eastbourne site today, I thought we would talk about major incident for Eastbourne Hospital. It's fairly similar for the Conquest site. The major incident policy is on the extranet, but I tried searching for it and it doesn't come up as major incident, it comes up as incident. So that's something I'll feed back to Kev Claxton. So you're thinking, what does this bloke know about major incident? Well, I've actually been involved in 3 proper major incident declarations since my time here. I've been a resource officer in Eastbourne since 1995, and I was an ODP for 9.5 years before that. It just makes me very old. So we've had 3 major incidents in my time. The first one was when we had 5 teenagers in a car who went over Beachy Head. Then there's the Lewis fireworks factory where unfortunately 2 fire officers died. And then the last one was the Berlin Gap gas cloud in bank holiday weekend in August. So let's move on. So if this thing will work. So like I said, the major incident plan is available on the extranet if you read it or not. Someone else has deleted my slides. So hopefully, I don't know what happened there, but all my slides disappeared. Hopefully you can see this. Like I said, brilliant, thanks Neil. There is a plan on the extranet, whether you've read it or not. One thing I would say is it's not easy to find, but probably the key thing is that you actually know your role. The thing with major incident is very dependent on everybody knowing their role. If you don't, it kind of falls apart a little bit. So you're not supposed to know everybody else's role. You just need to know your role. One of the key things for major incident is about what we would not do and what we do. So in an incident, we talk about normal rules don't apply. What we mean by that is for a day-to-day basis, we would probably apply a lot of resources into one patient, and it's flipped on its head for major incident. So we talk about doing the most for the most or the best for the best. So using my specialty as an example, normally resuscitation, we would put a lot of time and effort into resuscitating one patient. In a major incident, probably we won't actually resuscitate anybody, as in perform CPR, etc., which is a slightly different shift, and you need to adopt your mindset into that. What we normally do is different in a major incident. All right. So in terms of definition and actuality, this is the Civil Contingency Act. You don't need to know about all this stuff. In grassroots level, you don't need lots and lots of people to declare a major incident. In a nutshell, it's how many resources you have available at the time of the incident and the numbers of casualties and the severity of the casualties. So you don't need a set number to call a major incident. You can literally have 5 or 6 people, such as the teenagers in the car who went over Beachy Head, and that's sufficient to declare a major incident. So it's about resources versus what you're actually treating. People often think you need X number of casualties, and that's not the case. And just so that people are clear between what is hazmat, hazardous materials, versus CBRN, chemical, biological, radiological, and nuclear. Hazmat, in essence, is an accidental thing. Those lorries that drive up and down the motorway with whatever toxic substances, that would be declared a hazmat incident. Whereas if nasty people who want to kill us release something into the atmosphere to attempt to kill us, that would be classed as a CBRN incident. And for the people who are my age, you might remember the sarin attack in the Japanese underground a few years ago. So that's the difference between hazmat and CBRN. Basically, it's still bad, whatever it is, but it might be that CBRN is worse than the hazmat. Depends on the substance that you're dealing with. This is where the fire brigade come into their own, because they will know if it's hazmat, what it is and how to deal with it. Probably, pretty much. Now, people naturally, understandably, think when there's a major incident, it's always trauma, because we talk about major incidents because of things such as, slide on the right, the 7/7 bombings, etc. But of course, you can have a medical major incident. And a few years ago, we had Berlin Gap, and that is the scene when the emergency services were first there. I'll move on. So you can have a medical incident or you can have a trauma incident, and sometimes you can have both, fairly obviously. And then there's a classification. So you had a type of major incident, and then there's the classification of major incident. So you can have something which is simple, and what I mean by that, in isolation. So there's only one event occurring, and I, just because I'm a football fan, I chose Hillsborough, the football stadium disaster in 1989. Whereas you can have a compound major incident. This is nothing to do with fractures, in case there's any orthopods on the call. This is purely and simply that you have more than one event occurring simultaneously. And I just chose 9/11 as we're close to 9/11 again. And of course, there were several things going on 9/11, not just the Twin Towers, but the Pentagon and the other plane that crashed. So if you're not involved in emergency care, it can be confusing as to who you treat, how you treat them, etc. Where they go first, in a normal event, we have a trauma network. So patients that are critically injured will go to what we class as major trauma centres. Now, the major trauma centres for the southeast of England, as you can see, are predominantly London. That's our local major trauma centre. Obviously, Brighton is a major trauma centre, but Brighton does not take children in terms of major trauma. So if you have a paediatric major trauma, they get taken to London, or depends on what part of the county you're in and roads and weather and everything else, they may go to Southampton. So that's the normal process for significant trauma. However, in what we call a Big Bang exercise, and if you look back to the Nice terror attack, there was significant numbers of people injured, and this is one person in a truck. This will sound odd as a research officer. We're not interested in dead people in this scenario. We're only interested in the live injured patients. So if something like that were to happen locally, the MTCs would get the patients initially, but then, and I think 434 people is significant. Granted, they may only be walking wounded. They will then go to the next closest appropriate hospitals. and we have what we call trauma units. So Worthing, as an example, is a trauma unit. Eastbourne is not a trauma unit. Eastbourne is a local emergency hospital. Conquest is a trauma unit. But in essence, for a big bang exercise like Nice, patients will go wherever they need to go. But it's just so that you understand where patients go normally in significant trauma. And as we said, Conquest is a trauma unit. So they will receive trauma patients directly as a normal part of their pathway. Eastbourne does not get trauma from CCAM. We get walk-in trauma, but not brought in by CCAM. CCAM is South East Coast Ambulance Service for the people who are not aware of it. But if there is a big bang incident, to quote Kevin Claxton, you will get what you will get. So here in Eastbourne, we don't normally receive trauma. We don't normally receive paediatrics from CCAM. But if it were a big bang incident, we will literally get whatever we get. And I think we just need to be aware of that, because there's no point saying, well, we don't normally do this. In a major incident, you will be. In a mass casualty thing, there's a few things you just need to be mindful of. And that is, you won't be able to move people out of the hospital because there will be no resources available. If you're going to operate on them, it is damage control surgery. So you won't be able to spend 4.5 hours repairing a leg or something. It is literally do what you need to do to keep the limb or the patient alive, and that's pretty much it. And the other thing is, of course, any elective work needs to be stopped immediately, and don't be in a rush to start it up again, because you don't know what's coming in. So there's a lot of acronyms and pseudonyms and everything else, but just so that if you hear someone talking about methane, it's just a mnemonic that CCAM use to describe the type of incident or give us as much information as we can. So depending upon what you are and who you are in your role, we'll come to this in a minute, there's various alerts. So if we go on to major incident standby, what will happen in standby is relevant people will get together in the site office, which is in the Ed Centre, and they'll start to look at bed states, who we can discharge, who we can't, can we stop patients coming in, all this sort of stuff, in a preparedness state. When you go major incident declared, that's when we actually instigate our plan and go live. Hopefully you'll get the call that says major incident casualty evacuation complete, which means there are no more patients at scene, and then eventually it'll be major incident stand down, or it may be major incident cancel. Right? So they're the different alerts that you get from CCAM. But remember that we can declare a major incident internally if we feel that the resources are being stripped out because we're getting too many patients in, not business continuity, too many patients in from an incident, and we don't have the resources to cope. It's very political, I do apologise. So how this actually works, because I'm a sort of grassroots person, nuts and bolts, what really happens. So if you carry a voiceover bleep, so if you're on the cardiac arrest team, for example, and you have a speech bleep, if we declare major incident, the speech bleeps will go off simultaneously, like a cardiac arrest, but it will say major incident declared, activate plan. So if you don't have one, you may hear the bleeps going off. So that's how we use the speech bleeps, and then we will cascade call in. And there's a list that Switchboard use to start to activate the cascade call in, and they will call people in a specific order. That's been agreed by the board and Kev Claxton et al. Obviously, as part of your own department, you will probably have a cascade call-in system. How that works, hopefully your department knows. But in essence, person one makes a call person to two, person two then calls person three, or person one just stands there calling everybody in on the list. I know some groups use WhatsApp. WhatsApp can't be used for patient identifiable data though. But there's going to be a cascade calling. One of the things to be mindful of course, if the incident is ongoing, you may want to hold some of your resources back, so not drag in everybody all at once. Otherwise, if you're going for 24, 48 hours, you won't be able to sustain your service, whatever that service might be. Now, this is the bit that's some people feel uncomfortable with, and that's a thing called collapsible hierarchy. Now, in a very basic sense, unless you are the top of the tree, in your profession, whatever that means, you get given a task and you continue that task until relieved by a more senior person. So I'll use my example of Berlin Gap. Normally as a resus officer, my role in a major incident would be to go to resus and act as a priority one, either a team leader or a priority one team member. And if there's a cardiac arrest, I go to that. In Berlin Gap, I got given the task of being the bronze operational ED commander, thinking at some point someone will come and relieve me. No one ever came and relieved me. So, and I did that for 6 hours. So the point is, unless you are the top of the tree, and I'll just say a consultant, if you are a junior and someone says your job is X, you take that job, you continue it until relieved by a more senior person. Now, the person in charge of the overall major incident at shop floor level, it's not really shop floor, is the consultant physician on call. So I think I see Neil Sharma somewhere on the call. So if you are the consultant physician on call today and there's a major incident, you will be the overarching hospital coordinator, and you will, with a group of people, run the major incident within the hospital. However, if it's 3 o'clock in the morning, and no disrespect to the consultant physicians on the call, they might not be in the hospital at 3 o'clock in the morning. So therefore, collapsible hierarchy says that that falls to the next available person, which will probably be the medical registrar. If the medical registrar was busy because they're in the lab or they're just busy, that role will then fall to the medical SHO, etc. And that's how collapsible hierarchy works. So in essence, you get given a task, you continue the task until relieved by a more senior person. So more phrases, etc. So there's a thing called the ICC, which is nothing to do with cricket. It's the Incident Control Centre. And these are what we call silver command. So gold command is chief exec level, and they hang out in Lewis. Silver, they hang out in the ICC, and that's based here in Eastbourne in St Mary's Suite. So St Mary's Suite, for those of you who don't know, is opposite pharmacy. It's that part of the world. And like I said, the hospital coordinator is the consultant physician on call, along with site team and various other people, head of estates, probably security. There will be, if it's an incident that's involving the ambulance service, which it probably will be, CCAM will probably, should, send you a person called a HALO. And the HALO is the Hospital Ambulance Liaison Officer. And the HALO is the go-between from the scene to us here in the hospital. So they will be able to talk directly to the scene. But the ICC is Silver Command, and they hang out in St Mary's Suite. So if you are lucky enough to be the hospital coordinator, that's where you'll be going if you're the consultant physician on call that day. Now, triage, some of this won't apply to a lot of people, but just so that you understand how triage works, it's very different than normal triage in major incident. So we have a person called a triage officer. That's normally one of the senior ED doctors, but it can be anybody. There's a nurse and there's a scribe, and the scribe is worth their weight in gold plus some. The reason I put paediatricians in there as well is that if there is a paediatrician around, but remember, we only have paediatrics between X and Y hours, and then after that, there are no paediatricians on site, resident on site, we'd have to call them in. Those people will be triaging patients, and I'm going to walk you through how the triage process works, which for some people might feel uncomfortable. But it's a dynamic process. The principle of triage is that you get people through the front door. And the statistics suggest that triage, predominantly, you're going to get mainly walking wounded, which is probably very true. And I'm going to explain about P1, P2 categories in a minute. But you do have to bear in mind, people won't always come via CCAM. They may come through other emergency services, and classically they may self-present, which is what we saw in Berlin Gap. So what should happen at a place called the Casualty Clearing Station, which is normally facilitated by CCAM, they will look at the casualties, they will use set criteria, which I'll explain in a minute, and they will make them a P1, priority 1, urgent, as in must be seen now, life-threatening, P2, can wait a bit, P3, walking wounded, P4 dead or nearly dead. All right? And they tend to use things called cruciforms. The cruciforms are international, so there is a standard that everybody should work towards. But of course, patients aren't stupid, and they know that they can move the cruciforms around, and so if they were a P2, they want to make themselves a P1 and stuff like that. But also when they come through the door, they may have got better or worse depending upon the scenario. There are specific paperwork for major incidents, and there's a thing called a major incident casualty number. So we have a separate set of paperwork and separate X numbers, hoping that we can marry everybody up towards the end of the incident. And on that note, although the policy doesn't say this, it's going to be updated. So Eastbourne's the stroke centre. So if we had a stroke patient brought into us during a major incident, they would be included in the major incident numbers, just so that we can keep a track of all admissions into the emergency department. So we have priority 1, and these people go into the resus bay. So if you've never had the joy of going into the resus bay, we have 6 bays in Eastbourne resus. So allegedly we can take 6 P1 patients, provided there's no one in there. If there are patients in there, we will try to move them, but of course you can't move everybody straight away. Then the P2 patients, these go into the majors area. But if you've got a lot of P1s, you could in theory use some of your majors area to take over and become a P1, but that's where P2s go. P3s, they're the walking wounded, they go to fracture clinic. And then P4s are patients who are actually physically dead on arrival, so they won't get resuscitated, which seems odd, but they won't. They'll go directly to the mortuary, or patients who are in extremis and are what we class as expectant. So these are patients that are non-survivable. They're not actually dead, so they are still breathing, have a pulse. We will put them, it's been agreed that we will put them in the plaster room, because obviously we can't just leave them somewhere. So that's what happens at triage. Now, burns. For those of you not familiar with how the burn setup works in this part of the world, our local, in inverted commas, burn centre is Queen Victoria Hospital. Nice place, up at East Grinstead, about an hour away. So if we have 4 or more significantly burn injured patients, which in essence is a house fire, you can declare a major incident. I think it's unlikely we would get just 4 people because they would go somewhere else, but just go with it. You can ask the National Burn Bed Bureau for advice and support, and also Queen Victoria Hospital. They can send down a BAT team, burns assessment team, to help you. If you deal with paediatric patients do go to QVH. The London Burn Centre is Chelsea and Westminster, Brompton Road. It's a very nice hospital if you've ever been there. But burnt intubated children do not go to London. They do not go to QVH. They go to my old hometown of Chelmsford in Essex. Now, if you've never been to Chelmsford, it's 2.5 hours away. So that's the local paediatric burns ICU for intubated children. All right. Great system. So here we go. Let's talk about how we triage the adult patients. So triage of adults is based upon this protocol that's been developed by the Department of Health. Think of it like cooking instructions. If you ever use a microwavable meal, I'm not suggesting you do, but if you do, you follow the cooking instructions and follow the instructions and you'll be all right. So if you're involved in triage, or you're kind of involved in triage, you understand why we're doing certain things and not doing things to others. So go with it. The first thing we look at, do they have catastrophic hemorrhage? So if they have catastrophic hemorrhage, they immediately come across and are a P1 patient, all right? If, however, they have no catastrophic hemorrhage, then we come down, and what we then do is, are they walking? So if they're walking, they immediately become a priority 3. Now, this is where as clinicians, you cannot think too much. If you're walking, regardless of what's wrong with you, you're always a priority 3. So people will say, well, what if he's got a tension pneumothorax? What if he's got a subarachnoid? What if his arm's hanging off? It doesn't matter. The fact is you're walking. And if you're walking, you're a priority 3. And this heralds back to Napoleon's surgeon of the day, Dominic Jean Larrey, who had the principle, if you can walk, you can fight. So if you're ever involved in a major incident and someone says, can you walk? The answer is no, because that way you'll get bumped up, right? So if you can walk, you automatically become a priority 3. So if you're not walking, we come down the decision tree and we ask the question, are you breathing? If you're breathing, move on further down to the next assessment point, down here, all right? But let's just go back. The patient is not walking because they're on a trolley. The question we ask, are they breathing? If they're not breathing, we come across and they are dead, all right? So I'll say that again. They're on a trolley, they're not walking. They're not breathing, so they are dead. They are a priority 4. Now, I appreciate that seems very odd because that's not what we do, and as a research officer it's really odd, but that's the major incident protocol. Obviously, if your resources allow, so your priority 1 area, resus bay, is empty, and you've got 30 people in there gagging to do something, you may choose to resuscitate them, but the reality is that your resources are probably going to be super stretched, and putting loads of time and effort into someone who's already in cardiac arrest in a major incident may not be beneficial. So let's go back. So they weren't walking, they are breathing. Brilliant. So at this point, do they respond to voice? If they don't respond to voice, they come across and then they become a priority 1, a high priority. But if they don't respond to voice, then obviously we put them on their side. If you're concerned about neck injury, there are ways in which you can put people on their side and still protect their neck. However, if they do respond to voice, brilliant, then we count their resps. And I do accept that some people would argue about what is normal physiology, but if your resps are below or above, then you move into a priority 1 patient. However, if you have normal resps of 12 to 23, then you move on and assess their heart rate. And depending upon what their heart rate is, less than 100, then you become priority 1 or a medium priority, which is priority 2. And that's how we triage adults. And triage sieve is designed so that you can sieve people, each patient, in 30 seconds. That's the principle. Now, when we talk about pediatrics, obviously pediatrics is slightly different, partly because of their body size physiology, but also you've got the psychological stuff. So I just chose some examples of pediatrics major incidents in the United Kingdom throughout the years. Unfortunately, it does occur. We do get children involved in major incidents, and we need to be prepared for something if it happens. Probably the hardest thing for non-pediatric people is the psychological and the emotional issue attached with triaging children. Also, you may have to separate them from their families, so you've got to bear in mind safeguarding issues as well. And of course, paediatric resources, as we said on the Eastbourne site, after, don't quote me, but after 9 o'clock at night, there is no paediatrician here at all. The big thing with kids, of course, is that they may not be able to walk. They may not be able to communicate in the same way that adults do. And in a natural selection process, we tend to deal with a smaller child first than the bigger child. So let's go through paediatric triage, which is very similar, but not exactly the same as adults. And again, this may feel uncomfortable for some people. So first part here, are they able to walk? If they can walk, they immediately become a cross over to here, the priority 3 patient, all right? So anybody who can walk in a major incident is always a priority 3. When we do the major incident day, people always say, what about people in wheelchairs? Because not everyone in a wheelchair has to use a wheelchair full time. So the key thing is if they can get out of the wheelchair and walk, then they're a priority 3. But of course, they're probably in a wheelchair because they're unable to walk long distances. So if they cannot walk, we move down and we assess breathing, just like we've always taught you in resus. If they're not breathing, we come across and we think about their airway. So with adults, we don't, we just basically let them die. With kids, we think about opening their airway, so head tilt, chin lift, or jaw thrust. If they're, once you've opened the airway, if they are breathing, then they move across into priority 1. However, if you open the airway and they remain apneic, you move down and now you feel for a palpable pulse from a peripheral point of view. So they're apneic. If they have no palpable pulse, then they're a dead child. But if their airway is open, they're apneic, they have a palpable pulse, you can give 5 breaths. So with a bag valve mask device, you bag them 5 times. If they breathe after 5 times, brilliant, they become a priority 1. However, after you've bagged them 5 times, if they remain apneic, they're a dead child. And this is the bit that people feel uncomfortable with. So again, going back to your resources, if your resus room's empty and you've got loads of people there, you may want to resuscitate the child. But remember, we're trying to do the best for the best. We're trying to do the most for the most. And resuscitation, I'm going to slate my own profession now, resuscitation does require a lot of input and resources. So that's that part. But if they're unable to walk, then are they breathing? Yes, so we move down and we assess the respiratory rate. And again, I accept that normal paediatric physiology is varied, but the normal, according to Public Health England, if it's abnormal, they move across to a priority 1. However, if their breathing is within the normal confines, we assess palpable pulse. If there's no peripheral palpable pulse, they will possibly still have a central pulse, hopefully, then they become a priority 1. But if there is a palpable pulse, we move down and we assess their AVPU status. So if they score P, so they respond to pain, or they have inappropriate posturing, because obviously not all children are born 100% perfect. Some children have neurological disorders and their posturing may be normal for them, but if it's inappropriate posturing, which you may or may not know, then they move across to priority 1. Or if they score U on AVPU, they're unresponsive, then they become a priority 1. The way to assess verbal response in the younger generation, so for example, my grandson number 2 is a week old, he's not going to be able to talk to me. If you clap very loudly, jangle keys, hopefully they will respond to that noise. That's providing they're not hearing impaired, of course. So that's how we assess paediatric patients in triage. But the issue up here is always the bit that people feel uncomfortable with. Understandably so. So if the slide will move on. Now, the problem we have, of course, in a major incident is the resources are stretched and you may not be able to move people out. So CCAM, South East Coast Ambulance Service, may not be able to come and help you. Normally for paediatric patients, we'd involve South Thames Retrieval Service, who are based at Evelina Hospital in London. We would normally come and get them to come and collect the child and take them to London, but they may not be able to come. If they're not available, then we use CATS, which is the Children's Acute Transport Service, and that's North Thames. Our local regional PICU is based at Evelina, but they may not have any beds, and of course then there may not be any beds available in Hastings. We don't have any inpatient beds in Eastbourne for paediatrics. The times that when we would move people in this sort of scenario or another scenario is the time critical one. So we've taken them through the scanner, there's an obvious bleed, they need immediate surgical intervention. So we would transport them out, and that also includes significant burns patients as well. And those patients are normally taken by consultant anaesthetist and an ODP. The triage sort is this concept that you've got them through the front door and they're either a 1, 2, 3, and now you spend a little bit longer sorting them. So this is all a process of information communication. So ICC will always want to know numbers, as in how many people have come through the front door, and they also want to know the category, the state of patients, because that then feeds back to scene as to how many more patients of a specific category you can take. So sorting is a little bit more complicated. You probably need a buddy to do it, and you will need equipment, and if you're not very bright like me, you will need some charts, because I personally cannot remember the GCS. So let me explain how the triage sort works. So in essence, we look at the respiratory rate, we look at the systolic blood pressure, and we look at the GCS. and we add these various scores up, and that will give us a trauma score, and that trauma score then relates to a priority score. So if let's just say that you've got a normal rest rate, that will give you 4, your systolic's 100, that will give you 4, and you've got a GCS of 15, that will also give you 4. So that's 4, 8 and 12, and with a trauma score of 12 you become a priority 3. As you will have worked out, if we just go back again, you don't have to alter your physiological parameters much to suddenly become a priority 1 or 2. And I'm just going to finish up by talking about my experiences at Berlin Gap from a few years ago. So this was on a bank holiday Sunday. It was a very warm day, a bit like today, and there was a gas cloud occurred at Berlin Gap. To this day, we still don't know what the gas cloud consisted of. We declared major incident after CCAM had stood their major incident down. So the emergency services went to Berlin Gap, declared a major incident, no casualties came in. Then, a few hours later, casualties self-presented to the emergency department. The duty consultant of the day was Zygia Tesley. The consultant physician on call was Wyoming Pereira. The decision was made to declare major incident because people were literally rocking up with respiratory type symptoms. So we set up the tent, as you can see there. The tent gets erected at the front of A&E. So there's a sort of red crosshatch area outside the front of ED ambulance entrance. The porters will erect the tent, and then we were told by Public Health England to do wet decontamination. So my top tips for this: first of all, if someone asks you to get into a hazmat CBRN suit, don't do it if you have any form of claustrophobia. They're extremely claustrophobic. The other thing is, if you get in a CBRN suit, my advice is strip down to your underwear, but that brings with it its own issues as well, because you sweat like nobody's what. You then, if you're in the suit, you then wet decontaminate. Now this is not very fancy. You basically get a hose, a sponge, and literally the patients have to remove all of their clothing, and they go into a bag, and then you literally wash everybody down. Of course, what we learned from that is there are issues about privacy and dignity, understandably so, particularly when you had families present. So if you had, for example, a 13-year-old boy with their mum and dad, they don't really want to get naked in front of their parents. So that brings issues with it. Separation of smaller children was another issue. We had an issue that the water temperature was too hot, so we had to get states in to turn the water temperature down. And then, of course, if you've been in a suit, you then have to also get decontaminated when you come out of the suit. So that means that you've got to get naked in front of your colleagues. So before you go in a suit, consider all of those issues. You can only spend 45 minutes in a suit, then you have to come out. The other issues that we found is that we weren't expecting loads of people to self-present, so we ran out of paperwork fairly quickly. A few hours into the scene, we were confronted with the fact that we had 88 patients queuing. They wanted to go to the loo, we had no portaloos. So the area next to ED entrance is day surgery reception, some of you may know it. That got sealed off, and the patients used that as their point of toilet facility. So we are currently, to date, the hospital that holds the record for the largest number of wet decontamination casualties in the UK. They were all P3. Now, the reason there's an asterisk is some of them started to get, I think it was possibly slight overacting, some more severe respiratory symptoms, and so they were upgraded to a P2, only very transiently. But literally 133 people rocked up to our ED. So despite everybody's best efforts about major incident and casualty clearing scene and that, members of the public will still come to a hospital because that's what members of the public understandably, naturally, rightly want to do. So it's just to be prepared for all of this. And at that point, I'm going to stop talking. I do apologise that I'm not Salim Shuba. If you have any questions, then either unmute, put your hand up, put it in a message, and we'll answer any questions. I'll hope to answer any questions from the presentation. So over to you folks, if you have any questions. I can see Neil's hand up. Neil, fire away.
Yeah, hi Steve. Yeah, thanks for that. It's really great presentation. Just a quick question, really, about when if in major incidents you need to refer pediatrics, trauma, burns, they're going to other centres. What's the protocol on when those centres are full? So, for example, if you phone East Grinstead and they say, "Oh, we haven't got any capacity to take any burns," should they be taking control of all those patients and finding a secondary centre for them, or are they left with us to deal with?
That's a very good question, and I'll try and answer it, but I'm not saying that my answer is 100% correct. So with burns patients, we will talk to the National Burn Bed Bureau, because they allegedly have, on a day-to-day basis, they have an overarching view of burns beds throughout the whole of the UK. So
Okay.
there will be a lot of communication between yourself, because I appreciate you may be the hospital coordinator, yourself in Silver, in St Mary's Suites, National Burn Bed Bureau, and, for example, QVH. But there will be a lot of communication. But yeah, National Burn Bed Bureau are worth their weight in gold in that sense, because they will have overarching view of everything, hopefully.
And that would apply for sort of paediatrics. They have a similar setup and things like that.
So yes, so the
Yeah.
South Thames Retrieval Service, they should, again, you would discuss with them. They will have an overarching view of available paediatric beds. But again, it's all a lot of long-winded conversations.
Sure. Okay, thanks very much. Cheers.
Thanks, Neil. Anybody else at all who got any questions that they're anxious or confused about? So in summary, I think the key thing is that people know their role. You don't have to read the whole of them. Sorry, Ossie, you're there. Please ask away.
Yeah, I was a bit alarmed to find out that medical physician consultant on call is the person who is in charge of the major incident. I haven't had any training with that, and I wouldn't know what to do when this happens in future.
Yeah. So first of all,
are there any training processes available or simulation for medical consultants, etc.? Because one never knows when these things can happen again.
Absolutely. So first of all, I'm going to hold my hands up and say I don't write the policy. I'm just the messenger. So what I can do is I'll email Kevin Claxton, who's in charge of EPPRA, and I'll put you in contact with him. But yes, I mean, I think it's a very valid point, and I think a lot of physicians are not aware that they are the person who's going to be in charge. You will, to reassure you, Ossie, you will have support from other individuals. It won't be literally on your plate and everyone abandons you. But yes, you are the person who makes the decisions with support from other people. And yes, to answer your other question, there are courses. So we run a major incident course that's internal specifically, but I'll email Kev Claxton, copy you in, and then you folks can sort those bits and pieces out. But yeah, if you wouldn't mind spreading the word that if you're a physician and you're on call and there's a major incident, you are ultimately the person in charge. It'd be worth chatting to Wyoming and get her experiences of the day, because I think probably a bit like you, she was not surprised, but surprised that she was in charge.
All right, thank you.
No problem. Are there any other questions at all?
Hi, sorry, I can't find my hand.
That's all right. Hi, Victoria.
Hi, I mean, with the trauma, I understand. Trauma, it's mostly surgical orthopedic patients, and I agree with Osei. If we're dealing with something like, I presume bleeding and fractures, whatever, I mean, why medical consultants should be in charge of that?
So to again, hopefully to reassure you, this, I feel like this is Prime Minister's question time. So the principles that you as the consultant physician will work under is you won't be involved in the actual care of the patient. You'll be removed from the scene. So you're at Conquest, I'll stand corrected, but ICC is in the chairman's office, I believe, but I will stand corrected. So you won't be involved in the actual care of this person needs a laparotomy or this person needs this or that or the other. You'll be looking at the overarching position of the hospital. So bed state, resources, facilities, stuff like that, but supported by other people such as site manager, senior nurses, estates, facilities, etc. So you won't actually have to know how to manage a trauma patient because you will be removed from the actual scene of resus. Hopefully that allays some of your fears. Are there any other questions at all from anybody? I'm looking at the screen, I can't see anything. So, like I said, in summary, I do apologise. I was a last minute step in for Salim Shuba, so I'm sure Salim will probably come in at some point. I would definitely look at the major incident policy and your action card, because depending on what your role is, there will be an action card attributed to you specifically. I think it's well worth thinking about your department's cascade calling and how that works, and just also if you have trainees, making sure that they understand what this actually means for them. At that point, I'm going to stop talking. I'll leave you to go back to your normal sensible day. Thank you very much for your time, folks. Have a good day.